Chief of Neurovascular Intervention from Medicover Hospital at Visakhapatnam. It's a very pleasant evening at Visakhapatnam today. So we have a case where an elderly man is having recurrent brain stroke. So there can be many causes for brain stroke, and this patient is having recurrent brain stroke because is having intracranial atherosclerosis. Intracranial atherosclerosis means the blood vessel which is going inside the brain, the two major blood supply which are called carotid artery. So both the carotid artery in this patient has become narrow, they are tightly stenosed. So the more tight stenosis which is seen in the supraclavian IC on the right side is what we are going to treat. So the disease is called ICAD, or intracranial atherosclerotic disease, and generally they used to be managed with optimal medical management with antiplatelet and anticoagulation with statins. But now with advancement of interventional neuroradiology, what we are able to do is a safe angioplasty and stenting of these brain blood vessels. Let us see how we do it, the intracranial atherosclerosis treatment by angioplasty stenting today in these elderly patients. So our team has Parvati, who looks very calm today. So for next 1 week she is going to be happy, she told. So we have a very happy live session. Go ahead. From neuroanesthesia we have Dr. Pavani and team, and we have Prasad, who is our chief cath lab technician, and then we have Sai, who is from Deripo, and Dharma, hold the wire. We have Gauri, second in command to Parvati. Please. So we are trying to go into the right carotid artery. We have done an angiogram yesterday which is showing, can you show the 3D beta? So you can see the very critical stenosis over there in the supraclavian ICA. This is the stenosis. This is the right common carotid artery at the level of supraclavian ICA. It's a very tight stenosis. That's why the patient is having recurrent TIAs, that is transient ischemic attack, which is otherwise called as a mini stroke. So we have already gone into the right common carotid artery. Lateral please. We have stylist Sinu today, who is helping us with the camera. This is the lead glass which is protecting us against radiation. This is a very high radiation zone. Table please. Table down a bit. And we have, what's your name, beta? We have Prabin, who is from the team anesthesia with Dr. Pavni. So you can see this is the angiogram of the right carotid artery, which is showing this significant stenosis of supraclavian ICA, which is, can I have the screen closer to me? So we have taken the patient under conscious sedation. Sure. Navian. So why are you so happy, Amma? Navian. Yeah. So Navian 058 is the catheter that we will be choosing as the dyslexis catheter, which will take us very close to the lesion. So in those days, maybe about 5 years back, still there are a lot of discussion of the VOSIT trial and all this, that whether still we should be doing optimal medical management for these significant ICADs, or we will be doing intracranial atherosclerosis. But we have significantly moved in favor of doing an intervention, because that always, can I have the blunt end? that always helps us restoring the blood supply, and it has become significantly safe with the advancement of a lot of neurointerventional devices. So we really don't wait so much with a lot of medication, because chances of bleeding are very high when you are giving double antiplatelet plus anticoagulation. So patient can have intracranial hemorrhage or bleeding from the GI, are very, very common. So not really a good thing to have. So we have gone. So this is a distal access catheter from Medtronic. Right. And this is my Navion. Roadmap out, cable pleats, mag, table down, table pleats. All right. So we have. So you can see this is basically the cavernous sinus. These clinoid process, anterior clinoid and supraclinoid, the inferior clinoid process, and the anterior and posterior clinoid process basically. And once it is the ICA segment, which is beyond the clinoid, we call it supraclinoid. If you look at the angio here, you can exactly see that this lesion is at the supraclinoid portion here. Stop. So this is the ophthalmic artery, this is the clinoid, and that is the anterocoroidal artery. So ophthalmic, anterocoroidal, supraclinoid, and that continuous is MCM1. So this is our target today. We are going to use Neurospeed. Neurospeed we will use 3 into 8 millimeter. So the Neurospeed is a very specialized balloon which can navigate into distal architecture, angio architecture in the cerebral circulation, and is quite good to navigate. And it has 3 marker basically. The one is a distal marker, and the 2 marker behind the distal one are representing the balloon. And the distal nose cone is quite long, so it gives a lot of stability to the balloon, which we love. So from ICAD, this is the 3/8 balloon we'll be using today. We might go up to 10 atmospheric pressure, but we'll go very slowly.
Sir, wire also.
Papa, synchro. So we are going to take a combination of synchro wire, that is 014 wire from Stryker, with the Neurospeed balloon, and we will dilate the critical segments, and once we are happy we can put the stent across the same balloon. So today we had some consultant lunch sponsored by our department. Parvati could finish all the chicken, I think. So everybody was looking for chicken, and then this lady has. So we are slowly going there. So you can see we are slowly navigating across and gone into the MCA, and my balloon is, I told you about the 3 markers. This is the first marker, which is having a very significant stenosis here, so it's not easy to push because the nose cone is a little bulky here, so I have taken my distal axis a little further to give some kind of stability. So I have got a good loop of J in the distal area, so which is quite good for me. Hold the wire, step the wire. So here I have a challenge to push this nose cone beyond this critical stenosis. So in that case we might have to take a coronary balloon, beta. So in that case we'll take a coronary balloon and we can just about 2 millimeter, 212. So we can take a coronary balloon and we can create a path. So you might think that there is some really path over there, but you can see even it is not allowing the balloon, although we have a very two distal axes. We have a neuron max sitting here, we have navion sitting there, and still we are not able to push the balloon here because the lesion is very, very significant. So what we will do here, we just take out the whole system of the balloon and the wire, and we will put a low profile coronary balloon 2x12, and we'll create a little bit of path, and through that we'll put the neurospeed balloon. Now the question here can be, is it mandatory to put a neurospeed balloon? It's not mandatory. For example, we can take a coronary balloon and about say 3.5 millimeter we can dilate and we can create a very good channel. And then if you want to take the credo, you can take it with a 17 catheter also. That's also possible. So not mandatory to take the same balloon. And here I know it will be challenging to take a coronary stent and deploy it because of this lot of bend here, 1 and the 2 and the 3 and the 4. So we are not choosing a coronary stent, but you can try sometime to just push with a good distal axis support. Tracheals will help us. We'll go with 2.25 12. Amma, I'm taking it out. Total. And load the 2.25 on the synchro and give it to me. So what is most important in doing complex neuro intervention? The first thing is that you understand the anatomy, understand the disease better. You understand the anatomy that you are going to deal with. Then you understand your devices well, and you always have a plan A, B, C. And you should have a lot of energy and enthusiasm to redo the procedure if required multiple times without being worried. Because when you are very comfortable, suppose I change the axis here, I'm extremely okay to do that, then that's a good positive point to handle this type of situation. So we are taking a 2.25. Go back. Now hold it. Just to give you an impression there. Well, just to give you an impression, just check. So this is the neuroslider and this is the coronary balloon. You see, it's very low profile and tapered end for the coronary compared to the neuroslider. So this will go and help us to get a desired result. That's the plan, and we will go according to it. So there is some issue with our patient. He is very elderly and not really suitable for GA. That's why I love this loop. So we are not really keen to go and do a GA right away. You see this coronary balloon, which has, according to our plan and understanding, has gone very well beyond the lesion. And because the patient is not under general anesthesia, it's good to check with a little angio here for stop. You can see this. This is the lesion. My balloon is just across the lesion, and native. You see the balloon. You see this lesion exactly you have placed there. DSA. Now go ahead. Paroji, go ahead. Paroji will go ahead and do the angioplasty. She is a super expert in doing all this. Sai is there with us from Acandis, 2.25, balloon inflated. You can deflate. How's the blood pressure? So you can see this very beautifully done. Yeah. Stop. Good. Go ahead. Put the balloon. Put the slide. So the ICAD, the intracranial atherosclerosis, is very common in Asian population, especially Indian, Chinese, and Japanese and Korean. Basically, people who are diabetic, people who are rice eating, most commonly the ICAD is seen in them. Parle the wider. We'll see. We'll try once a little bit. Roadmap out. Mac tapu. Yeah. Table up. Table up. Yeah. So table up. Yeah. Wide out. Yeah. So we are just using a very interesting technique here. So now you can see this balloon has just crossed across and gone into the desired location and beyond. Always it's a good practice to table down a bit. Yeah. Max mag. All right. Wait. So we are trying to take an injection from the seat. So it's quite beautiful. Wait, Maparo, stop. So here we have the neuroslider in place, and then we are just placing our 3 into 8 millimeter balloon here. The nose cone is longer, which is giving us a lot of support. Go slowly. 1, 2, 3, 4, 5, 6. Okay, deflate. Oh, that's a very good lumen. Then we can go ahead and put a stent. Beta Sai Kumar, there. Stop. Yeah. Are you ready with your stent? So from the basically right from the below the choroid, we'll start to place the stent. So we are using the same balloon to push in the stent. Can I have the 520 credo? Why connected there? Yeah, please. So we have the 520 credo ready with us. कौन सा है बाबा? पारो जी. La la la. So basically diabetes can cause a lot of arterial disease. In the brain it will cause intracranial atherosclerosis and diabetic ophthalmopathy or retinopathy, and then in the neck is responsible for creating carotid artery disease, heart coronary artery disease, subclavian stenosis, aortic aneurysm, renal artery stenosis, abdominal aortic aneurysm, peripheral arterial diseases. So diabetes is something one should be very careful about and should have a good control, otherwise you are going to land in problem. So my professor those days in MBBS days at Cuttack SCB Medical College used to say that diabetes can cause everything except pregnancy. Go ahead please. So can I have a light here? Are you okay? Light on the hop. Yeah. Smooth. तेरा तो सब स्मूथ चलेगा, 1 week के बाद पुन टाइट हो जाएगा. Stylish Shinu is smiling a lot. Huh? You should always be fine, Amma. Right? You are the boss of the department, Parvati, right? Right, Shinu?
Yes, sir.
Yeah.
Shivagami.
शिवगामी अच्छा दे
Bahubali.
बाहुबली दे रे बाबा तू के स्टेंट पे ना तू इतना टेंशन का ले रहा है so beautiful credo stop come here all right so we'll take a quick check run ಹೇಗಲ್ಲ 2 minutes okay beautiful there stop roll back on that yeah
తను యాంపిల్ ఉంది చూడు ప్రొఫెసర్ ఇంకా కావాలి ప్రొఫెసర్
beautifully positioned so you are opening the credo nicely opened so leave it so it is placed exactly where we want it all right there. So you can see the credo is placed nicely and make sure of one point that there is no more scope of angioplasty right now with a laser cut stent placed there. Oh, you can see the beautiful run here, extremely good, and it is placed beautifully right from the clinoid, right from the distal to the choroid, proximal to the anteroidal and to the bend where we have planned. Exactly, this is what we wanted, right?
Yes.
Yeah. So Sai was suggesting something. I said you don't have to talk. That's okay. We have decided. So this is what we are doing. But he has extremely good knowledge of the device. No doubt about it. So we have placed the stent. It looks so beautiful. Thank God. Thankful so much. So this is extremely beautiful. Epicranial. Table, please. Oh, extremely good. You can see the ACOM just came in. The ACA started opening up, and the circulation in the MCL looks much denser. We'll show you better. Can you just save it here and go to the net? The previous NGO. Mundo. Yeah, the 6. Yeah. You see. So now you see this is the circulation. Here we got a denser circulation. We pop out and start feeling much better. And you see the new ACA came in, which was not there. The antecerebral artery on the right side started filling from the ipsilateral side. That is going to be a great boost to the patient. And we are so happy. Cover the head. Yeah. So this is beautiful. Bladder. So as I said, patient is not under general anesthesia because it's not fit for anesthesia because of multiple issues. So we choose to do it without the anesthesia, and he cooperated very well and with some sedation. Please. Dr. Pavni and team had did a great job in terms of anesthesia. So it's looking great, and we're going to stop here. Thank you so much, and you all have a pleasant evening, and we will come back to you with another new case. Thank you so much. Good night. Save. कौन साई बाबा हैप्पी तो stop huh? how to save huh? This one share this one which one I think the live the X